So we've got a little bit of a gap now before Thibaut's going to be ready with the final case. So we thought what we would do is have a bit of a round table, but we would like to open it up to questions from the floor. So I don't know if you've got any questions about anything that you've seen, but if you want to think of something to sort of start the meeting going. Yeah, we'll keep the lights on. So Dan.
So I was wondering if you could discuss how you each would have managed that fistula when it was discovered, in terms of what you'd cover it with, how or if you'd administer any steroids, and any ways you might manage the patient differently.
Okay, so I think we can all agree that was a really tricky case to do live at a meeting, but you get an unexpected fistula, and I don't know whether it was seen on the pre-op CT, but certainly on the audiogram you would not have expected anything like that. So what are you going to do with that, Manahar, and particularly with regards to steroids?
Yeah, so I suppose you have to go to your internal models of what you think the biology is and what you can do to modify. I probably would use steroids because all the animal models suggest that the earlier you get steroids, and the more likely to prevent hearing loss. But the downside, you could prevent healing around the fistula because of whatever patch you put on, potentially. But I probably would give steroids. In terms of how I deal with it, I suppose some of these big fistulas I've left and come back a year later, and there's developed a fibrous kind of thing, and you can peel it off more easily. So that's something I might have tried, but that's a very unusual fistula, I must say. So I would probably do something unusual for me, which is leave it for a bit. Most times I take it off. The other concern I have is that you might get a conductive loss just from the shunting, local shunting, because like a third window dehiscence. So reconstruction, I think, would be difficult to gauge the effects. And you might even get some tulios and other vestibular complaints when you connect the fistula like that up to the tympanic membrane. So I probably would have left that reconstruction personally, and I might have even left taking the rest of that thing. I definitely would have given steroids, I think. But it's just because of my internal model, how I think the biology is and how I could modify it. But I don't really, can't say I've ever seen a fistula in that location and had to deal with it. Well, yeah. Yeah. Well, if I was going to repair it, I would put something like fascia, but I would reinforce it with something rigid, because I think if you leave a compliant member in there, you're going to get some local shunting. So bone pate is what I would use. Yeah, probably. Yeah, I usually use tissue with my bone pate. Yeah. Yeah. Yeah, just so you get a rigid repair. Otherwise, you just end up with local shunting of the fluid. I mean.
Any comments on that? So we've got a bit of fascia or perichondrium over the fistula with maybe some bone pate and tissue on top of that. That's one option. So you put the bone pate over the open fistula. Do you worry about it migrating in? Yeah, but this one wasn't intact, was it? I don't think the endosteum was intact here. I think we were looking directly at the fluid. Yeah. And I think if you got intact endosteum, then it's fine. But I think with this, I'd be worried about that.
The first problem is, must you remove completely the matrix from the fistula? First thing, I think that some special places during the dissection must be postponed at the end, and especially when you can suspect. And these are the area of the canal, lateral canal, the area of the oval window, and especially for the cochlea, which is very rare disposition, and probably more dangerous and for the future. And so you prepare all, and you let the matrix on the fistula for the first time. And when you come back, you try to remove it, which is often not so dangerous. But sometimes when you see that you are opening, some people say, let the matrix, keep the canal wall up technique, and come back eventually 1 year later. And sometimes you have the surprise that there is no pearl. But it is more easy 1 year later to remove the pearl than remove completely the matrix if you see that you are opening the perilymphatic.
Okay, so sort of just summarising that. So basically, when you're doing your dissection, you leave that area where you suspect right till the end, and then lift it. And as long as you've got some endosteum, you take it. But if you don't, then you leave. But I think the problem with this one, it was unexpected. I don't think any of us quite saw that coming.
Just a plea. I mean, I didn't actually see it because I was out talking to Wilco, but this is one of the reasons you take your graft material at the beginning of the operation, because the thing you've got to do in this situation is think quickly and put something over the fistula if you think it's leaking while you have a few minutes to compose yourself and decide what you're going to do. I haven't got an answer on the steroids because I only found out recently my anaesthetist has been giving steroids to my patients for the last 23, 24 years without telling me. He says that's why they don't vomit when they wake up.
I think most anaesthetists do that now, John, but you know, I'm sure that was news to you. But
no, but this is right from the beginning. So, you know, you don't need to give any more steroids. They already had them.
Well, maybe you do give a bit more. I don't know. I think a lot of us would give more. And the other question is whether you give them into the cavity.
Yeah. Well, the other thing to think about, and I forgot to mention this, was that when you go in this time, this is an infected mess, right? It's got, you found leucopus in there. So if you're going to open it up, you're going to introduce all kinds of biological infectious agents. I would prefer to open it when it's a sterile cavity if I could. So that's another thing to think about in the sort of biological model you build in your mind how you deal with this thing.
Does it matter how large the fistula is in terms of staging? If it's...
Yes, I don't know that there are specific millimetre parameters, but the traditional teaching was that if it's more than 4 or 5 millimetres, then it's safer to leave rather than remove the matrix. And the same if it's a cochlear fistula rather than a vestibular fistula, it's safer to leave matrix rather than risk opening the cochlea. You know, if we know from our experience now with semicircular canal plugging and procedures that you can safely open the vestibular labyrinth and seal it and not lose any hearing whatsoever. But we also know that you can't open the cochlea like that and with the same level of safety.
Okay, so I think we'll just go on to our general approach for cholesteatoma now. So I'm just going to ask our panel first. Any of the panel who would routinely do a canal wall down as routine surgery for cholesteatoma? No, so they're all canal wall up. Yeah, I'm not saying there's anything wrong with it. I'm just, yeah, okay. And do any of the panel here routinely do a primary bone pate obliteration with a canal wall up, like Owen officier? Anybody do that? Yeah, I'm beginning to do that now. And anybody do that at a revision? So they do a canal wall up, and then they see some recurrent disease maybe in the attic at 6 months or a year, so they're going and doing a second stay. Does anybody obliterate then? Yeah, so that's more common. And what do you obliterate with, Dwayne, if in that situation?
If there's bone pate, I'll try bone pate first, but I am...
What do you mean if there's bone pate?
Well,
the patients in the UK have got a thing called a skull, so they have bone pate.
So no, I appreciate that, but if there hasn't been a massive mastoid done before, or something hasn't come from somewhere else, and I can get enough bone pate, I'll use bone pate. But we're trying this Bonalive bioactive glass. We've seen some good responses, so we're busy with a little bit of a in-house trial on that. I've so far only done about 5 and great results.
Just in the audience, does anybody else use Bonalive? So we've got 1, 2, yeah. Okay. So Bonalive is a bit like Serenasem. It's a glass granule that comes in different sizes, and it's meant to be bioactive and it's meant to stimulate bone formulation. I have a bad experience, and you may have heard about Serenasem, which is an aluminium trisilicate. It's a glass ionomer, and it comes as a cement that we talked about yesterday, but also comes as a granule. And I obliterated quite a lot of mastoid cavities with that, and we've subsequently found that you get erosion of the bone, sometimes quite extensive, around those granules, and the products have been withdrawn worldwide. So I'm slightly skeptical about, but I mean, I'm not saying that there's anything wrong with Bonalive, but I personally am just a little bit skeptical. Bone pate, I don't believe, has that problem. It resorbs a bit. I wouldn't say it resorbs a lot. But what do you use when you obliterate?
I do use bone pate, but I have no problem taking the canal wall down and reconstructing the canal wall too, which I have done a lot of. And in that case, because the bone pate is supporting your graft, you really do see it go back, and you know that bone pate has resorbed to some extent. But I think that's a perfectly valid option. Take the canal wall down, reconstruct, and I've done lots of cases like that too.
Yeah, so the origination of this obliteration technique was, somebody alluded to it before, was Ulf Merker in Sweden, who from the 80s was doing a combined approach and then chopping out the posterior canal wall, taking that bit of bone, obliterating. He used a soft tissue initially, so he was using muscle and cartilage, and then put the canal wall back. And then people have looked at that and using cement to fix the canal, and then more latterly, Erwin Officier and Bruce Gantz have been suggesting that you leave the canal wall intact and obliterate with bone pate. And I think that their evidence is that reduces recurrence. And my own experience, and I think maybe you guys, when you're coming to a second stage, it does seem to reduce recurrence. But obviously you worry about burying disease. So
It also makes it a longer and more tedious procedure.
To remove the wall.
No, to do a bone pate obliteration, the procedures described by Bruce and by Erwin and the Antwerp approach is, that's a 4 or 5 hour operation they're doing. It's a long, tedious operation. I'm not quite sure why it takes quite so long, but you've got to get all the bone pate material.
it doesn't, honestly, I do it, and taking the bone pate takes 15 minutes. I mean, it definitely does. There's always bone, so you just go back. They've got a huge skull, so there's never a shortage of bone. And then at the end, you just shove it in. It doesn't take that long, honestly, Rob. I mean, I don't quite get why it takes a long time.
I understand. I've not actually watched them do it, but I've seen their videos, and the report is that it takes a fair while. It depends, I think, on your approach, and my current approach is to try to achieve, in the longer term, an aerated mastoid. And so I generally used a staged procedure with a sheet of silastic through the facial recess at the first procedure. And I find that when you come back for the second stage and take that out, the mesotympanum is beautifully aerated, and the mastoid often is less aerated. But once you take out the silastic sheet and the fibrous capsule around the back of the sheet, which there usually is, then often the rest of the mastoid will stay aerated, and it allows a much more stable vesicular reconstruction at that second stage procedure.
So that's an interesting thing. So how many people do that? How many stage routinely nowadays? And we always used to stage because we had to do a second look for disease, but we don't now because of MRI scans. How many people routinely do a 2-stage procedure for cholesteatoma? Can I just ask the panel? Lots of shaking of heads. Anybody routinely do that?
Not routinely.
Well, I see a slightly different cholesteatoma than you guys. I mean, I'm seeing large numbers of poorly done atticoantrostomies, which I'm still correcting. If I see a primary cholesteatoma, I'll do a combined approach, but quite often I'll turn that into a small cavity with some degree of obliteration, but I don't rebuild the posterior wall. But in terms of second look, and if I've got any fears that there may be something there, I would certainly have a scan, but I don't routinely do a second look. Certainly don't do a second look. And
on this side of the panel, guys doing routine second looks, because I've completely changed my opinion. I used to exactly that, and now I do a diffusion weighted scanner a year, and I always reconstruct primarily, and I almost feel the other way, that the primary reconstruction almost helps my tympanoplasty and helps my ventilation of the middle ear. I might be wrong, but it sort of stents it up, and I think I get better results doing a primary reconstruction.
I pretty much agree with you. I think I'm not sure that the prosthesis helps. Maybe it does in terms of reconstructing the middle ear space, but in terms of the second look, I think if you have good anatomical results, you have good hearing results, an MRI, and you have to be very careful about these MRIs. You have to know your radiologist well. There's plenty of places who will say they can do a DWI MRI, but they have to know the technique of a propeller. I don't know the technical reasons why. It's a very specific type of diffusion weighted image. It's not just a diffuse weighted image. It has to be a very specific technique. And in New York, I only have 2 people I can send it to. So all the radiologists will say they can do it. But the truth is, you have to find someone who really has experience with it and knows how to look at the details and be able to tell you whether there's a cholesteatoma to the limits of the resolution, which is what,
About 3 millimeters.
3 millimeters. So so you have to be. But if you do have that, if you have that available, then it's certainly I think it replaces the need for a second look.
And I think it was interesting, Thibaut was talking about a CT scan, but if you've got a dry ear with good hearing, I can't see any point doing a CT scan. Of course, you do an MRI, you've got to look for disease. And what I do them at a year, and then I see patients every year and then scan them at 5. And if everything looks okay at 5, I discharge them.
Does any of the rest of the panel feel it depends on your population?
Yes.
Some of the people here are operating on patients who they're never going to see again, and others, like us, are operating on patients who we know are going to come back to us. And, I stick the cat among the pigeons. If I'm operating on a patient who I suspect I'm never going to see again, I may not go for a cap. I may go for a small open cavity.
I completely agree. And I think if you're doing a modified radical mastodectomy with the aim of producing a cavity, then there are very established techniques to create a small cavity. Take the mastoid tip off completely, shelve the walls of the cavity as much as possible, rotate some soft tissue in, middle temporal fascia flap, posterior muscular flaps, use some bone pate, and possibly use other materials like the Bonalive, but I don't have experience with that. And these and a generous, adequate meatoplasty, all of these things allow a stable, dry, small cavity. And if you're not got adequate follow-up, that's safer probably.
About the MRI scanning, I do it a lot, but it depends to me it depends a lot on what I find. If I'm not happy with that I got, that it was very extensive everywhere, then I would nearly always go back. But I think you have to be careful what kind of MRI scanner you have, because the Causse and all have the single shot non-echoplanar imaging, which is I think the Siemens scanner, and then other people have the Haste imaging. We have the GE scanner, which only does propeller. And otherwise you get the susceptance artifacts with it. And in our study that we did in our scanner, we had a 25% false positive rate when we compared intraoperative findings to the scan, and we had a 15% false negative rate. And I'm still finding false positives. I'll go in there on the kid and there's nothing there, even though there's a little thing. So I think you have to be really careful. The scanner at your center, the Belgian studies all with a single shot non-echoplanar, which I think is the best one. The GE scanner can't do that sequence, so if you have a propeller imaging, it doesn't have the same sensitivity. I don't think anyway in our center.
Yeah, and I think certainly if you have any suspicion, you forget what the scan shows and you look. And I have to say, this particular case that we saw, which I thought was very tricky, it was one of the few ones I wouldn't reconstruct, and I would definitely do a second stage on that. I think if the primary surgery you've got any concerns, you should go back and look. Good. Any other questions from the floor? Cholesteatoma surgery. Yep.
Do you ask for a CT scan before perform any surgery in chronic otitis media or not, even in dry ear?
Routinely, yes.
I think if it's
to check
clinically
the
cholesteatoma, then it's a very good idea to get a CT preoperatively, and it helps you to plan your surgical procedure. It helps you to identify preoperatively complications such as a fistula, the size of the degree of sclerosis of the mastoid, the position of the sigmoid sinus. Simple things like that really help you with your preoperative planning. But if it's a dry, simple perforation, then I don't believe you have to have a CT scan.
Yeah, we use it routinely because even if the hair is dry, sometimes it's interesting to know the anatomical condition. And there is a discussion about do I perform a mastoidectomy or not? So it means that if you want to perform a mastoidectomy, it's better if you have the CT scan. So you have the choice.
So if you have a dry perforation, how often would you do a mastodectomy though?
Not so often, but If I see some opacity in the mastoid and it is not an sclerotic process, maybe I will do a mastoidectomy.
Any other thoughts on that? I mean, I think that clearly there's an issue of cost, and there's a slight issue about radiation, but I don't think there's ever an issue where people say, "Oh, I wish I hadn't done that CT because it's given me information." You know,
And
you're never going to say that.
In Melbourne, we now have a new cone beam CT, which I have to say is fantastic. It's much lower radiation than conventional CT, much easier for the patients, although it is a lie-down one. And the quality of the resolution of the vesicular chain and the middle ear detail is much superior to the previous CT as
So
well.
who else has got
really good.
access
This is
to
true,
cone
but
beam
in
CT?
France we have a problem with the cone beam because it is not reimbursed by our national health system. So it's and we have a real problem to propose to the patient.
And I think it's important, you know, this we don't have, we're actually getting it, but we don't have it yet. But this case illustrates that the CT is not foolproof and the sensitivity is, you know, good at best. And so just the fact that you don't see a fistula doesn't mean that there isn't a fistula. So.
But if you do see a fistula, it's quite
then
nice
it's
to
great,
know, you
right?
know.
But
I think in Canada we really fight the radiologists in children because the MDCT, the radiation dose outside of cone beam, which is lower, but then the cone beams takes longer, so the kids sometimes won't sit still for those. Anyway, the MDCT dose in radiology really push back now if you order a CT scan in children because of the long-term risks. And so when we order a CT in a child, it's almost like you have to really justify it, in where I was working anyway.
But did you? So for cholesteatoma,
Yeah.
would you routine it?
I was so used I grew up with it and I was so used to having it pre-op. I did, but I think if I'd stayed a bit longer I might have been talked out of it because they keep presenting the long-term risks of radiation in children, and I was starting to get convinced that there was something going on.
We still do the cone beam for our cochlear assessment, and I agree with Rob. I think MR is superior, but we're trying to learn a new field because if you shoot it at a certain angle, you can actually miss the globe, and so for the small kids, we don't, there's no radiation on the globe, and that's really what you're worried about. So with the cone beam, so.
I mean, I never used to scan, but those of you that have been to the course before, over 2 decades, I've been battered down, usually by David Morgan, who's not here. I've been here for the last couple of years, basically saying I'll be on the other side when this goes to court. And so I've started to scan, although I don't necessarily feel it's necessary. And I think it's becoming a medical legal issue as well, and that's quite often we change our practice because it's a combination.
I agree with you. I mean, in primary cases, I don't feel the need to scan. I'm a bit wary because of the medical legal implications, but I go in with, expecting to find a fistula at the canal of the cochlea of the hissing.
I'm going to meet every single complication.
Exactly.
The scan says so or not.
Yes, exactly.
There's no difference.
Well, for revision cases, it helps, I think, because you just don't know what happened before, and it's different anatomy. But I agree that, personally, I don't feel that in primary cholesteatoma cases, it does not make such a big difference.
For your planning, though, like Rob was saying, you've got a very sclerotic mastoid. It's nice to know that. And you
might be the only point where you go in with the intent of doing a canal wall down or not.
Yeah,
but
yeah.
You're going to find that quickly enough.
And I think it's like fashion of monitoring. Monitoring is not absolutely necessary.
Agree.
For acoustic neuroma surgery, it would be negligent not to monitor because there's a very clear evidence that the intraoperative monitoring improves the outcomes. That's not the case with the Causse clinic doing tympanomastoid surgery, because the key thing is to find the nerve anatomically and dissect it carefully, and you see it. And there's no evidence that actually improves the outcome. But it does, I think, increase the safety. And once you are used to using it, it does give you a degree of confidence and familiarity. And
But I think the thing with the monitor that's different is, did you have a monitor in the theatre? No. There won't be a problem. Did you have the monitor in the theatre and not use it? There will be a problem.
And if you and your anaesthetist aren't familiar with using it, it's no good to you. So.
And in Canada, do you use a monitor?
Yeah, always. We had a consensus statement in our Otology group, and the consensus was that it was standard of care.
For
for mastoid surgery, for Tympanoplasty surgery.
Non-drill surgery, marinoplasty.
We only we're talking about mastoid, yeah.
And America, that's the same.
I think honestly, I don't think it would matter anymore legally if whether it's in the room or not in the room. I think if you're doing a mastoid particularly and there's an injury to the facial nerve, I think you're screwed if you don't have a monitor. So I think you need to monitor.
Yeah, interestingly, at the Sisson Head and Neck Conference a few years ago, I asked about using a nerve stimulator on doing parotid dissections, and at least 50% of the people in the room didn't. And I said, why on earth wouldn't you? You stimulate the main trunk at the end, the whole face moves, you know it's okay, even if the patient weaks.
And you say a few years ago, John, are we talking 20 or 30
we're
here?
talking 10. We're talking 10. We're not talking 30.
Because I think that's probably changed. And definitely the CT thing, it's interesting. We've been running a course for 18 years together. And at the beginning, people like John grew up before CT scans. So when he started doing mastoid surgery,
It's a slight exaggeration. He's not that much younger than me.
CT scan didn't exist. But he was operating before anybody did a CT scan.
it was
so
before
then you have to
drills,
say,
wasn't it?
why do you change your practice? You know, I'm doing my
I
surgery.
was
it's
only
fine.
talking to Valsalva the other day and he was agreeing with me.
But for the younger surgeons, I think certainly in the UK, I don't think anyone would think of doing mastoid surgery without a CT scan. But I don't know, probably worldwide that's a little bit different. I guess. What about Portugal? Do CT scans? Yeah. So just show of hands, facial nerve monitoring for mastoid surgery if you use it. And you don't use it. I think we had this a bit before. And you don't have it. Who doesn't have facial nerve monitoring? Hands up. So a few people don't have it at all. Okay. Right, well, I think we still have a little bit more time. What about post-operative care of your mastoid cavity? So what do you pack with here at the clinic, Benoit? So I hope you've all met Benoit. Benoit was one of the star surgeons who we used to watch every year and admire greatly, and he looks very, very happy. He's happy and relaxed, and that's because he retired 2 weeks ago. But it's great to have you here. So what do you over the years, what did you pack your ears with?
I use some Silastic to avoid any adhesion, and gel foam and Merocel.
And this is in the canal?
Yeah.
And what about in the middle ear? What did you do
in the middle ear? All my procedure of the middle ear, I let some Silastic in the middle here. At the beginning, I used a wide Silastic sheeting going through the posterior tympanotomy and posteriorly, but I did not continue to do that because when there is only one stage, and I let the Silastic in the middle here, because in the middle here, when you use a medium-sized Silastic, not 4 millimeter, which is too thick, and not 1 millimeter, not 0.15, which is too thin and it rolls, but 0.25 is the right size, and you can let it. And when you have a CT scan after, you can see the slight Silastic and no reaction at that level. I completely agree. So I let Silastic inside. I use gel foam to maintain the graft. But at the end, I used more and more the cartilage. Cartilage became very, very interesting, especially in those ears which are sometimes evolutive, and which was very interesting.
When you were using the cartilage, did you leave the perichondrium on it, or just cartilage under the drum?
It doesn't matter, because I always use a large fascia.
You always use fascia as well.
Yes.
And during your career, what were the sort of evolutionary steps, the things that you felt you were doing differently at the end, which were advantageous? You know, if you want to share your experience.
But at the beginning, it was a two-stage procedure, and then it became one stage. So you have to make the ossiculoplasty at the first stage, let some Silastic inside, and sometimes you have some reaction in the mastoid, but not in the middle here. So I reduced the size of the Silastic, and I quite always use because I learned that canal wall up techniques, very, very, very rarely canal wall down techniques. At the end, I use more and more cartilage and then use the obliteration when there is a revision, when we have a recurrence of the disease, the obliteration of the mastoid and the attic with bone pate.
Okay.
Of the attic only, not the entire mastoid, right?
No,
Just
no, all the posterior cavities.
What's that?
So the attic and the mastoid.
And I asked this person, you might have seen John House consistently just put a piece of muscle in the attic. And I don't know that he's ever published that, but he always said that reduces recurrence significantly. I know the new studies are about obliterating the entire mastoid. So,
but I'm sure it's the attic that's the key thing, because that's where the recurrences occur, isn't it? It's usually that anterior.
Right, but that's my question. Because going back to it being a long surgery, I mean, if you just have to obliterate the attic, it doesn't add that much to your cases.
I think one of the reasons it can add time is that you need to be reasonably careful at getting rid of mucosal disease, so you actually strip out the mucosa before you obliterate. What I'm not sure is what happens. Obviously, you can never get rid of all the mucosa, so what happens to buried mucosa underneath in pate? And I suspect it doesn't really matter very much, to be honest.
It probably just involutes, and it may well be that some of the squamous epithelium does as well, that you don't get growth of pearls and things because it's pressure controlled and involutes, but I don't know.
So that's another interesting question. So let's just say at a year you do your diffusion weighted MRI scan and you see a 2 millimeter pearl and everything's beautiful. It's got a very healthy ear. It looks like it's in the mastoid antrum. You've got good hearing. Do you automatically go and remove that, or do you rescan, or what do you do? Mark, sorry.
Well, I think it depends. It depends on what happened at the primary surgery, how confident you were.
So you're quite happy with your surgery. Let's just say this. You're quite happy with the surgery, and you're very happy with the post-operative result. Looks great, lovely ear, good hearing, but you do the scan, and you're surprised to see this little pearl.
I tend to, if it's a really small pearl and it's at the edge of the sensitivity of MRIs, again, depends on what you have.
Yeah.
I tend to wait and rescan in a year.
Yeah. The position is evolving.
Yeah. Position is important. Of course,
we have I revised some cases very recently to present in another meeting, and we have 4 false positive over 11. 4 over 11 with diffusion. With diffusion. And I have the comparison between the MRI diffusion, TSE, or those by Philips, but and the MRI with injection and late diffusion, and the comparison with CT scan. And for the 4 cases, all the images are typical of a residual. But when you operate, Thibault operate one and I have the other. It was in one case cholesterol granuloma with a very thick material inside the kyst. The second was, in fact, something which is with bone dust and some inert material. And the 2 were mucosa or something very unspecific. So it means that I agree. I wait now 6 months more, and I do another diffusion. And if it is growing,
then you do it.
I know.
Okay, I think that's good advice. Okay, so we're going to have a final question, and then we'll go over to speak to Thibault.
The use of, I don't think this is working. Use of lasers, painting. So you're saying stripping mucosa before you obliterate.
Yeah, so what I do when I obliterate, I drill with a diamond dust burr, and then I go around with the laser and paint the cavity at 1 watt continuous, and just paint the mucosa. I do that routinely. Even if I'm not obliterating, I go around, and particularly the areas where there's been squamous epithelium. Anyone else do that?
So Chris, you use a fibre even if you don't think there's any disease left there?
I use a fibre on every case, yeah.
Okay.
He comes from where those poor schoolboys live, so
no,
they can afford the fibre.
No, but I'll only open the fibre if I think there's a question mark. But I may be wrong.
I think using a diamond drill is and meticulous removal of the matrix is just as effective.
And the mucosa.
Correct.
Because I know about mastoid. But the question is, in the middle ear, do you intentionally remove the mucosa, or do you just try to separate the cholesteatoma from it?
I don't remove all the mucosa in the middle ear. I think that probably leads to adhesion. So if there's an area I'm concerned about, I'll strip the epithelium and I'll laser that area, but I don't routinely take all the mucosa.
So-
Only
so-
when I'm obliterating. So if I'm doing a combined approach and not obliterating, I'll leave all that mucosa, but just laser the areas where the squamous epithelium was.
I agree. That's the question.
Okay, I think we'll go to T-Bow now if that's okay. So thanks very much for that extra bonus session